This is the title page I really like for this presentation. I like it because it has a little preview of what's coming. You'll notice on the left side there's a bottle with a cork in it and a circle slash superimposed on it. And the reason it's there is to remind us that sometimes babies get stuck in the maternal pelvis like corks in bottles. This stuckness is the source of most of the things that we treat as body workers when we're seeing babies who have tethered oral tissues and, frankly, babies who do not have tethered oral tissues. This is a picture of me giving a baby a craniosacral therapy treatment. I'm a former birth doula and a retired home birth midwife. I attended births for over 40 years all in all. About 12 of those years I was a midwife. I've also been a therapeutic body worker for the past 33 years. That's a long time. The kind of body work I practice is craniosacral therapy. I specialize in treating pregnant and postpartum people and also infants. I have been independently teaching infant and perinatal craniosacral therapy for more than 15 years now. The ultimate goal of my work is to end war. The way I've decided to do it is to improve infant and parental bonding. If babies and their parents have better births, and if the babies are in better condition at birth, they are more easily able to form secure attachments. When babies form secure attachments, they're more likely to thrive in healthy families. Healthy families contribute to healthier communities and a saner, safer world. I know I won't see the results of my work in my lifetime. And if I did, I would not have asked a big enough question. Here I am teaching a prenatal yoga class. Before I talk about yoga, I want to talk a little bit more about my obsession with helping people have better births and better quality babies. This quest has led me through doula work, prenatal massage, craniosacral therapy, childbirth education, midwifery, super specialized craniosacral therapy for pregnant people and babies, and finally prenatal yoga. Over the years, the cesarean birth rate has increased dramatically in the United States and certainly in other industrialized countries. While most babies are medically normal, we've been seeing a huge increase in subtly compromised babies in our free infant craniosacral clinics here in Portland. The same is true in my private practice. I've spent years developing and teaching perinatal craniosacral therapy techniques. They're designed to improve mobility in maternal bodies so babies will have more room to move and assume more ideal positions for their continued gestation and ultimately their better births and healthier infant development. Over time, though, I realized that bodywork alone may not be enough to solve the problems we've been seeing. I figured that it was theoretically possible to develop prenatal yoga classes that would help accomplish my bodywork goals for pregnant people. The most important goal is to make space in pregnant bodies so that babies can assume more ideal positions for gestation and birth. Therefore, I reinvented myself as a prenatal yoga teacher in my 60s so that I could reinvent prenatal yoga. I'm a longtime yoga practitioner, so this wasn't too much of a stretch for me. Although, actually learning to teach yoga was hard for me. I'm really proud that everyone in this room is doing the same thing. That means I succeeded. Every single one of these people understood my instructions. This is a picture of my students giving craniosacral therapy treatments to pregnant and newly postpartum people in one of my classes. So I got interested in craniosacral therapy early in my bodywork career. I had attended births as a labor support person for family and friends before I ever became a body worker. All along I was seeing babies who were medically normal, but they had issues that I intuitively knew I could do something about if I just had the right tools. In 1992, I was at a monthly breakfast meeting that was mainly attended by home birth midwives. That's a long time ago. I figured they had magical powers, and I just wanted to maintain a low profile and hang out with them and not be discovered as an imposter and thrown out. Sometimes one of them would ask me what I did, And I would say, well, I'm a massage therapist who also goes to births. That was a pretty bulky title, but in those days, the word doula had not been used to describe labor support work. At one of those meetings, I overheard one midwife ask another if she did cranial adjustments on all the newborns in her practice, and she said, yes, I do. I was too shy to ask what that was, but I knew in that moment that I needed to learn how to do it, whatever it was. So my original intent for taking craniosacral training was to learn about this infant cranial adjustment thing. But my training included next to nothing about pregnant people or infants. So I had to adapt the techniques I had learned about non-pregnant adults to fit the population that I was actually seeing, which was pregnant and postpartum people and babies. So I've also had to invent a lot of new techniques. I can remember sitting in a class and hearing the teacher say, "Don't do this with a pregnant woman." Of course, I was thinking to myself, you're way too late. I've already figured out how to position her. This was especially true for the visceral techniques I learned. Sadly, that fear about female bodies being a delicate collection of complicated parts ready to go haywire at any moment has spilled from prenatal and birth care into the realm of bodywork for pregnant people. I'd like to talk a little bit about craniosacral therapy. Craniosacral therapy has evolved as a specialized branch of osteopathy. Osteopathy was developed in the United States in the late 1800s by Andrew Taylor Still. So it's a form of drug-free, non-invasive manual medicine. So at first, osteopaths weren't especially concerned with the structures in the cranium. They had been taught the British model of anatomy, which is widely taught in the UK, big surprise, and other English-speaking countries, the former British colonies. Anyway, that model of anatomy holds that at some point in our lives, our cranial bones fuse and that our heads are like coconuts. So why develop techniques for a part of the body that doesn't move? But early cranial osteopaths like William Sutherland and Charlotte Weaver disagreed with that head as coconut model. They noticed that not only were cranial bones slightly movable, but they also had a palpable movement or rhythm of their own. So we call this movement the craniosacral rhythm or the cranial rhythmic impulse. And there are a variety of theories about the source of this rhythm. And frankly, it's only one of a very large number of assessment and treatment tools available to craniosacral therapists. The real thing about craniosacral therapy that sets it apart from other kinds of manual therapy is that it's incredibly gentle. And of course, that incredible gentleness is, I think, one of the reasons that it's become such a popular technique for parents to seek out for their babies, because everybody agrees that we're not going to hurt the babies while we're using a few grams of pressure to seek out areas in their bodies that don't move very well and to help restore movement, thereby restoring function and, we hope, eliminating the source of pain. Craniosacral therapy has some basic guiding principles, and the most important one, or at least the first one I'm going to discuss, is that the body seeks balance. And we all know from our physiology training that about homeostasis, right? That we have this biochemical balance that we're always adjusting. Well, we also have structural balance in our bodies, and we're always adjusting that too. So we capitalize on that inner drive of the body to seek balance. And our job as craniosacral therapy practitioners is to create the appropriate conditions for the body to find that balance. The next principle I want to discuss is the interrelatedness of structure and function. So imagine that this baby has a tongue tie, okay? So that's a structural problem. We know that it's a failure of apoptosis, and this baby developed this condition in utero. So what's the functional issue here? This baby cannot elevate her tongue, among other things, of course. But that lack of tongue elevation means that she cannot apply pressure with her tongue normally on her hard palate. So that's a functional issue. In turn, the hard palate begins to develop a high arch. That's a structural issue. When the hard palate develops the high arch, It crowds space from the nasal cavity. Okay, that's another structural issue that leads to another functional issue, disordered breathing. So that's my favorite example for this group anyway, and it's an important principle that we take into consideration with craniosacral therapy. All of our body parts should move independently of their neighbors. So it's really easy to think about bones and muscles moving, but everything has to move. Organs, blood vessels, nerve fiber tracts, and especially the fascial networks in the body. All of these structures need to move. And when they don't move the way they're supposed to, we develop pain and loss of function. The next principle is that the source of pain or loss of function is not always obvious. When I treat a baby, I take a really careful history. I want to know everything about the pregnancy and the birth to the degree that those things are known by the people who bring the baby for treatment. I want to know the treatment goals for sure. And once I've recorded all of that information in my chart, I disregard those things and treat what I find without regard to what I think I know about a baby. The reason I do it that way is that I get better results. Rote protocols, I think, in this particular type of body work really don't serve us well, and it makes much more sense to me to use my palpation skills and treat what I find. The body has great wisdom. In this case, it's a baby body. This baby knows exactly what position they need to be in order for a release process to work the best. The therapist is not positioning this baby or holding the baby or encouraging the baby to do anything at all. What she's doing is she's supporting this baby in gravity while the baby does the moving in order to release whatever needs to be released. We're on the second to the last principle. This one is all healing is self-healing. My clients do it on their own with my help. It's happening inside their bodies. My job is to create the conditions for that healing to occur. The last principle is to use the smallest intervention necessary to stimulate the body to do its own healing. I don't really know exactly what has to happen. I don't have an obsession with getting body parts to stack up or align a certain way. Again, my job is to assess for subnormal mobility and to use, in this case, in all cases, the smallest intervention necessary to allow the body to restore the movement that is the hallmark of vibrant life. Several years ago, I met a French osteopath named Bruno Conjot. He was at a small conference that takes place over several days each year. Some of the participants are from Europe and some are from North America. There are generally anywhere from 6 to 20 people in this particular conference, and everyone presents. It's only for craniosacral teachers. So Bruno's presentation was about something he called ground floor syndrome. Essentially, babies carried too low in their mother's pelvises. So not long after he began his presentation, I totally wanted to walk out, but this was a small gathering. It was a great honor to be invited, so I stayed in my seat. So Bruno showed slides of pregnant women. He went on to describe how some of them had bellies that looked bad and others had bellies that looked good. That's right, good pregnant bellies and bad pregnant bellies. I was like totally outraged. So who was this guy? What could he possibly know about pregnant bellies? Didn't he know that every pregnant person has a unique shape? Didn't he know that every person has the right shape for them and their baby? So how dare he say that some pregnant people had the wrong shape of belly during pregnancy? I'm a midwife after all. This guy knows nothing. Women are simply different, not bad or good. Each pregnant belly is unique. He said that the uterus is a lot like a hot air balloon. He said that the ropes that stabilize the hot air balloon are like the support structures that stabilize the uterus. He said that when there's tension and imbalance in these structures, it's a problem. So by the end of the conference, after talking with him more, I began to see things his way. Here's an example of a good belly. So this baby is not super deep in the maternal pelvis. The belly does not have that squarish look of a baby in, say, the classic occiput posterior position either. And in case you didn't know, occiput posterior is a significantly less than ideal position for a baby. This is a bad belly. This baby is very low, and assuming that this baby stays there for days, weeks, or months prior to the onset of labor, it's for sure a problem. After the conference, I continued to think about Bruno and the ground floor syndrome. I evaluated it from both a midwife's and also a body worker's perspective. As midwives, we spend most of our time building relationships and waiting for nature to take its course. We pay attention. We ask the midwives questions, which are, what's needed in this moment? Do we need to do anything? Could we do less? What would happen if we did nothing? What's the smallest intervention needed to get things on track without unduly interfering with the process? So my midwifery experience has always informed my bodywork practice. One of the reasons I love craniosacral therapy so much is that it resonates so well with the midwife's questions, especially the one about what's really needed in the moment. Likewise, my bodyworker self has been present at each prenatal visit, each birth, and each postpartum visit. I've always had a technical perspective of how exactly babies fit into and ultimately through a maternal pelvis. Another way to say this is that I've always had a biomechanical perspective about birth. So, is everything I know wrong? Given who I am and the accumulation of my experience, I eventually had to let go of the idea that Bruno was wrong about the good bellies and the bad bellies. In fact, most difficult births have something to do with less than ideally positioned babies. And this is not just breech or a transverse lie. These malpositions may be subtle, and they're usually long-standing, beginning days, weeks, or months before the onset of labor. I used to travel to teach craniosacral therapy, and when I would travel to another city, there was always somebody who would host me, and that person would have a variety of responsibilities, one of which would be to recruit the babies for the free clinic associated with the class. And I remember very clearly in 2011 teaching an infant craniosacral therapy training in the San Francisco Bay Area. My host was a physical therapist who was also a lactation consultant. And she did a great job. She got the right number of babies, which is sometimes challenging, although I was utterly disappointed by the end of the class. Nearly every single baby who came to that clinic had feeding issues. And many of them had tongue ties, and some of the tongue-tied babies had release procedures, some of them hadn't, but nearly all of them had feeding issues. And I was super disappointed because I felt that due to her profession, that was the population she was seeing, but it differed significantly from the population that I was seeing in my free clinics in Portland and in my private practice. I felt like the babies we saw in the Bay Area were heavily skewed toward feeding issues, and I was seeing a broader array of babies in Portland. Well, guess what happened? I swear from that day forward, everything shifted. In Portland, 90% of the babies had feeding issues. A whole ton of them had tongue ties, and we've never gone back. This has all caused me to think about the babies I've seen over the years who have feeding issues not related to tongue tie or that don't resolve post-tongue tie procedure. These are medically normal babies, but they have torsion or lateral flexion patterns or both in their bodies. They have asymmetries, they have autonomic nervous system dysregulation, sleep issues, digestive issues, etc. Some babies have palpable asymmetries in the floor of the mouth. I mean, obviously that's going to affect feeding. Some of them have asymmetrical movement patterns. They can't move their tongues in a symmetrical manner. Some babies have really super disorganized sucking patterns. Some of them do better on one breast. Some of the mothers have nipple damage only on one side. Some of those breastfeeding parents use different holds on each breast. They may have a cross cradle hold for one side and then a football hold for the other side. When these babies also have tongue ties, all of these other things that I'm describing, the things that are the result of fetal constraint, those things I consider to be the comorbidities. Some of the parents that seek treatment for their babies already know that their babies have tongue ties. And when they come to us with the knowledge, but not having done a procedure, they fall into different categories. Some of them want pre-release treatment. That is so totally awesome. I totally love that. There is a lot that we can do to help these babies have better function after they get a release procedure, because we can help eliminate some of these comorbidities, these other things that interfere with their normal functioning. There's a second category of parents who have identified that their babies are tongue-tied, and they want to try craniosacral therapy first to see if it'll work, and then they won't have to get a procedure. Well, fat chance, right? If babies need procedures, they need procedures. Getting Bodywork, though, in advance, again, will help those babies recover more easily from the procedures and function better also. There's another category of babies who have actually mild tongue ties, but more significant comorbidities. They may have really serious torsion or lateral flexion patterns in their bodies. They may have restrictions in the fascia in the cranial base that has an effect on the exit locations for certain cranial nerves that are responsible for coordinating suck, swallow, breathe. And those babies, if they can get some decent body work going, they can usually avoid a procedure because the tongue tie itself was minor and the other issues were exacerbating what was there. And then once we get some body work happening for them, they're going to function within normal limits. Some of the babies have such autonomic nervous system dysregulation that as body workers, we're concerned that these babies will just end up over the edge with some kind of oral aversion issue after a procedure. And so for those babies especially, we want to get them settled down. And of course, there's always this delicate timing and sequencing, like we've got a milk supply to preserve, we've got a parent who may be ready to throw in the towel on producing milk for the baby, and we want to get the baby functioning as quickly as possible and get a procedure for a baby who needs one, but we also want the baby to receive the benefits, the full benefits of the procedure by, we hope, settling down some of the autonomic nervous system dysregulation, helping to release some of the structural imbalances in their bodies that lead to impaired function. So let's look at a couple of babies that are really pretty standard issue babies in terms of the kinds of things we see in the free clinics and also in my private practice. So twisted baby number 1 has a head rotation to the right. Now, when I say to the right, I mean the baby's right, not the right side of your screen. This baby's left ear tilts toward the left shoulder, and there's some significant tension between the eyebrows on this baby. And overall, this baby isn't tense. In fact, they have relatively relaxed looking hands. The baby's right orbit looks a little smaller than the left one, so there's sort of an asymmetrical face shape on this baby. And there's a pretty significant crease between the right side of the baby's nose all the way down to the lip crease on the right side. The baby's lips are asymmetrical. The baby's tongue placement is asymmetrical. This baby's holding their tongue on the left side of the mouth only at this point. By the way, this baby has a tongue tie, but you can't tell that from looking. There's a lot more that I think we could figure out about this baby with some palpation too. I mean, in this setting, all we can do is look. And one of the other things that we see is that there's a lot of blanching and tension on the left side of this baby's chin. And last but not least, this baby appears to have no neck. Shoulders are hiked up on both sides, elevated on both sides, I would say. And this baby probably has some spinal accessory nerve compression. Can't tell, though, until we start to feel things and really get in there with our hands. So let's take a look at twisted baby number 2. So this baby has an anterior rotation of the left shoulder. And again, I mean the baby's left shoulder, not the one on the left side of your screen. Likewise, this baby's right pelvis is also anteriorly rotated. Now there's a significant C curve in this baby's body. The concave side of that curve is on the baby's right side. The baby's left shoulder is elevated, the baby's right shoulder is depressed. And the baby's right hip is elevated and the baby's left hip is depressed. And just like twisted baby number 1, this one appears to have no neck and a cute smile. There's another group of babies that we've been seeing who don't have lateral flexion patterns and they're not twisted. They have an extreme full body flexion pattern. Their chins are tucked and they have a significant foreshortening of the superficial anterior line of their little baby bodies. They're curled up in tight little balls, way tighter than what you would normally see with a typical newborn. Because the superficial anterior line of the body also includes the floor of the mouth and the tongue, it makes me wonder if some of these babies are getting tongue tie procedures and maybe not improving dramatically afterwards because they didn't really have a failure of apoptosis. And it also makes me wonder if these babies are getting tongue tie procedures because they did have a failure of apoptosis, but in addition to that, they have this extreme flexion pattern. In any case, these extreme flexed babies really need some body work, and they need a focused home care plan too that helps them strengthen the posterior side of their body so that they can develop extensor strength. When I see babies like this, I've learned to ask the magic question. Here's the question. Was your baby in one position and really low in your pelvis for a long time at the end of your pregnancy? Guess what? The answer is always yes. They say, wow, how did you know? I felt like I had the baby between my knees. She was so low, I could barely walk for weeks and weeks and weeks. My baby dropped. People usually say this with great enthusiasm when it happens. I've never really understood why people rejoice about their babies dropping. Why do they think it's so cool? Do they think it's proof that they won't be pregnant until the end of time after all? Do they think that their labors will be shorter because the baby is 1 inch closer to being born? Do they believe that the babies won't now be able to turn breech or into some other undesirable position? I really don't get it. The medical term for babies dropping is engagement. The dictionary definition of engagement is fixation of the fetal presenting part in the maternal pelvis. For some reason, we believe that fixation is the norm for first-timers and for a smaller number of second and subsequent timers. We believe this is true because we think that once someone has driven a baby through the pelvis, things move better, so those second and subsequent babies will bob in and out of the maternal pelvis throughout gestation. End of theory. P.S. This theory doesn't hold water. Fixation means stuck. By the way, babies rarely get stuck in ideal positions for continued gestation and birth. So why do we think this is normal? Is it normal? No. It is assuredly not normal for babies to be jammed into the maternal pelvis, unable to move around for days, weeks, or months before the onset of labor. This is actually the opposite of optimal fetal positioning. We think it's normal because it's common. However, common isn't necessarily normal. I decided to look at some research because I was really curious about the prevalence of fixation. I found this awesome study published in the British Journal of Obstetrics and Gynecology in 1975. The fact that it was published in 1975 actually makes it especially awesome because it was unusual for women to have their labors induced in those days. This study included women who were up to 42 weeks gestation with their first babies. The researchers wanted to know if it was really true that engagement occurs in first-time mothers between 36 and 38 weeks gestation. That's what was and is still commonly believed. I'm using the word engagement here because that's the term the researchers used. I really want to call it fixation, though. So guess what? It's not true. At least it wasn't true in 1975. By 38 weeks, only 23% of the people in this study had engaged babies. In 50% of the cases, engagement occurred between 38 and 42 weeks. So remember, this study was done with first-time mothers, primips, okay, at a time when most women did not work outside of the home. And if they did, their occupations were way more likely to be active than they are now. So my guess is that if this study were to be done today, the outcomes would be different. We would see engagement or fixation happening way more often and way earlier in pregnancy. Here's the next study. It was published in the International Journal of Biological Research in Pregnancy in 1983. This study looked at the relationship between engagement, or fixation, at the onset of labor. They found that there was no engagement at the onset of labor for 75.4% of first-time mothers, and it had no effect on birth outcome. This next study was published in the Journal of Nurse Midwifery in 1995. So these researchers found that 69% of first-time moms had babies who were not engaged even in early labor, and this alone did not predict birth outcome. So the popular culture notion is that somehow, I guess, people think that babies won't get born if they don't engage, that somehow diving deeply into the maternal pelvis for some extended period of time is essential for a successful birth. And I'm here to tell you that actually the opposite is true. But it's amazing. I've had people ask me how to do it. How can I get my baby to engage? And a really quick Google search will produce an inexhaustible supply of articles about how to make it happen. Sadly, some scheduled cesareans are done for lack of engagement. So I was in the room when this baby was born via a scheduled cesarean for other reasons. Note the baby's hand gesture. So how did we come up with the idea that fixation is normal for primips, first-timers, in the first place? Well, industrialization plays a role. This idea got started when most pregnant people did not work outside of the home. So here's my theory. Back when most women in industrialized countries did not work outside of the home, they were more active than today's office workers. Most of them were doing housework and yard work. Nonetheless, some of their babies became engaged. The women who did not work outside of the home and who already had children at home were even more active because they were up and down off the floor, picking up children, picking up toys, etc. Because they were more active, their babies were way less likely to engage. So nowadays, most people who identify as women work outside of the home, more than 70% in the United States. Fixation is on the rise. 50 years ago in the U.S., more than 50% of jobs required at least moderate physical activity. Now, fewer than 20% require it. This trend is occurring in all industrialized countries. Seated occupations are the norm. So how do people get to work anyway? Well, most people either drive or ride in automobiles. Some people ride in public transportation. Public transportation seats, and especially automobile seats, are notorious for forcing the pelvis into a posterior tilt. And a posterior tilt is absolutely the worst position for a pregnant pelvis to be in. And working from home doesn't change things much. trying to do office work at home usually has us seated in a dining room chair with essentially substandard equipment, a non-ergonomic setup. And so I would argue that if you're saving yourself from the ravages of automobile rides by working from home, you might not be doing yourself any favors. So what about when we're not at work? Well, you guessed it, sedentary lifestyle in general is also part of this problem. So why is this a problem again? The more time a baby spends in utero in one position, the greater the tendency for the baby to assume and grow into that shape. So here's a common scenario. Imagine that one day at 30 weeks, a baby drops very low into her mother's pelvis. On this particular day, she lifts her chin a little and happens to have her left ear tipped toward her left shoulder. Her mother is very busy with a work project that has her seated at her desk for long hours. She's exhausted after work and spends the rest of her waking hours propped in bed watching TV with her pelvis posteriorly tilted. This gets the baby stuck. The next day, the mother continues with the work project, again seated for long hours. The baby begins a 3-day growth spurt. Now she's really stuck, like a cork in the bottle. Remember the cork in the bottle? So this picture shows a full-term infant skull in the occiput anterior position, passing through a normal female pelvis. There's plenty of room. This picture shows the same skull positioned with the baby's chin untucked and the left ear tilted toward the baby's left shoulder. The exact same scenario I just described. Same skull, same pelvis, a nuanced change in position, big problem. That's my hand in the picture. In this position, it was impossible for me to force the skull through the pelvis. This nuanced, less than ideal position is called asynclitic. This one is also slightly deflexed. The earlier it happens, the worse it is. I rest my case. If you remember nothing else about my presentation today, this is the one thing I want you to remember, and that is babies grow into available space. So this picture is a picture of real watermelons. They're grown in boxes, and of course they assume the shape of the container in which they're grown. And I am here to convince you that the same thing is true with human babies, that they also assume the shape of the container in which they're grown. And if they don't have room to move around, they may assume a less than ideal shape and ultimately have less than ideal function. These watermelons, by the way, are incredibly popular in Japan. Babies are too. So I've already talked a little bit about why so-called engagement is a pathological condition that potentially adversely affects the birth process and subtly or overtly affects the condition of the babies after birth. So I've explained why this is primarily caused by seated occupations and seated lifestyle for pregnant people. And I'm now going to talk to you a little bit more about some other maternal factors that play a role in babies getting stuck. So some people have differences in the bony pelvis that contribute to baby stuckness. So we're not talking about that garbage pail diagnosis of cephalopelvic disproportion, CPD, which isn't a big head or a small pelvis. It's actually a baby head that would fit nicely if only it was pointed in the right direction. So think asynclitic military OP presentation, that kind of stuff. Sometimes there's weird pelvis stuff. There's really weird pelvis stuff that hardly ever happens, like you had rickets as a child due to extreme vitamin D deficiency, or fractured your pelvis as a teenager, and you now have a bunch of hardware holding everything together. So there isn't much you can do about the things on the weird stuff list. You do what you can do to mobilize the parts that will move and keep your fingers crossed. So there's also some ordinary pelvic stuff. Sometimes it's less weird. It can be something like a stuck sacroiliac joint, SI joint. Did you know that your pelvis has joints? They are supposed to move, especially in the birth process. If they don't, birth can be a rough ride for both participants. In general, joints become more unstable during pregnancy. That's so your pelvis will move like crazy to get your baby born. Sometimes these joints move a lot during pregnancy and get stuck in the process. When this happens, you may be able to yoga your way out of it, but probably it's time to see an osteopath, physical therapist, chiropractor, or other body worker who can get you unstuck so your baby doesn't get stuck. The midwife in me says both yoga and body work, the belt and suspenders approach. Pelvises have similar but different shapes overall. As different as we look on the outside, the same thing is true on the inside. We humans are all similar with unique individual differences. These different but normal pelvis variations rarely cause problems. So what about the support structures of the uterus? So some people have a lack of mobility in the so-called ligaments that support the uterus and the associated female reproductive and pelvic organs. I use the term so-called because technically ligaments connect bones to bones. This is simply not the case here. Nevertheless, they're called ligaments. Really, they are fascial structures. All of the whitish stuff in this old-timey illustration is fascia. It surrounds, envelops, and in some cases permeates the muscles, organs, and other structures in the pelvis. One of the many functions of fascia, because it's slippery, is to allow adjacent structures to glide against each other. This is really important. The illustration isn't entirely accurate in that there's no actual empty space between the structures. The spaces are included in the drawing so we can see the various parts better. In reality, everything in there is tightly packed and touching. All of our body parts are supposed to move independently of their neighbors. When they don't, we have problems. Glide matters. So we give different names to these so-called ligaments, like round ligaments, broad ligaments, or uterosacral ligaments, but it's really all one interconnected fascial structure. Adhesions or restricted mobility in one place can affect movement somewhere else. This is a biggie. This can inhibit a baby's ability to move because the uterus and other pelvic organs can't move normally. Trust me. That's a bad place for things to not move. It's like squeezing a balloon. Speaking of balloons, another way to visualize this could be to imagine the uterus as a hot air balloon with the ropes attached to it. Remember the story about Bruno? So if we tug on one rope, it has an effect on all the other ropes. It also has an effect on the size, shape, and orientation of the whole balloon. Another maternal factor is uterine differences. Some people have a heart-shaped uterus, one that has two separate sections divided by what's called a septum. This is called a bicornate uterus. These and other anomalous shapes can make it harder for babies to move into more ideal positions. There isn't much we can do about these things, although keeping the parts that can move mobile may yield a better outcome. Some babies share the uterus with fibroids, which are non-cancerous tumors. If fibroids grow big enough or are in certain locations during pregnancy, they can interfere with baby movement and ultimately interfere with normal birth. If they're big and high in the uterus, they can interfere with the baby having the space to turn into a head-down position. If they're big and low down, they can block the way out when the time comes. Another factor is uterine scars. Some people have a scar on their uterus. One way to get one is to have a cesarean birth. You can see the skin scar in this picture, but this person also has a scar on the uterus. Scar tissue simply does not move as well or in the same way as surrounding tissue. It could be one source of a potential problem. Some people have restricted movement in their abdominal organs, their stomach, their liver, their intestines, etc., that give the baby less room to grow upward into that area. What's a baby to do? They grow down deeply into the maternal pelvis or outward toward the rest of the world. Both scenarios are less than ideal and present their own particular problems for birth. Focused, specific manual therapy can address these things. In a perfect world, these issues would be addressed before pregnancy. In fact, these same things, both restricted abdominal and pelvic organ movement, can play a role in infertility. Makes sense, right? We need better movement for improved blood flow, nerve conduction, and overall normal function. Can we do this kind of body work during pregnancy? I'm going to commit heresy here and say that it's good to do it. I've been doing it for years. I teach it too. This is a photo of my students. The prohibitions against it were established by someone, probably an early osteopath, way back when, who didn't actually treat pregnant people and who saw them as frail beings inhabiting bodies that were likely to go haywire at any moment. This myth has been passed from teacher to student for a very long time. Some people have restricted movement of the iliopsoas muscle group. We all know we have muscles near the outside of our bodies. These are deep on the inside. The first one is the psoas. There are two of them. In this illustration, you can see them peeking out from behind the kidneys. The kidneys are the things that look like smooth beige potatoes, at least in this illustration. They make their way all the way down through the pelvis to a special place somewhere near the top of the femur, also called the thigh bone. And that special place is called the lesser trochanter. Down in the pelvis, the two fan-shaped muscles, one on each side, called the iliacus, line the inner surface of the big flat bones that make up the back and sides of the pelvis, the ilia. They also dive down through the pelvis and end up approximately in the same place as the psoas. Whole books have been written about these muscles. There is great speculation about whether the psoas should be classified as a muscle at all. Some think it's a sensory organ that happens to have muscle tissue like the tongue, but I digress. What's important here is that the imbalance in length and strength in these muscles can play a role in babies getting stuck in the maternal pelvis. They are also key players in the birth process, guiding a baby's way out. Interestingly, when a birthing person has epidural anesthesia, it renders these muscles flaccid. They can no longer guide the baby in the right direction. Food for thought. What helps? You guessed it, yoga and manual therapy. So what about the pelvic floor? Who among us doesn't have baggage down there? There's a lot of talk these days about weakness in the pelvic floor. The general response is to squeeze everything down there and hope for the best. The problem with that is lots of people really don't have weakness. They have what's called hypertonicity. Squeezing everything down there and hoping for the best makes it worse. That's right, too tight. The muscles pull the bones together as far as they will go, and there's nowhere else to go. You leak urine and maybe squeeze even tighter, making the problem even worse. Some people have both low tone and too much tone in different areas. It's important to have a healthy balance of strength and ease throughout the pelvic floor. Still, other people have neither tightness nor weakness, but they lack the ability to fully recruit or connect with the muscles of the pelvic floor. Of course, there are many other pelvic floor issues that can contribute to baby stuckness. How do you find out what you have? Get professional help. There are physical therapists, chiropractors, massage therapists, and others who specialize in evaluating and treating pelvic floor issues. There are also specific yoga practice that can help relax or strengthen the pelvic floor. An ideal practice would be done after you know for sure which scenario you have and where. Your yoga practice for your pelvic floor would be customized, relaxing one side and strengthening the other, for example. These are the fetal factors, things about the baby, that cause fetal constraint. There isn't much we can do about the fetal factors aside from resolving the other things, maternal and cultural, that we can readily do something about. As I've mentioned, rarely is there just one thing causing fetal constraint. Multiples have less space. More than one baby equals less space to move around, period. So look carefully at these twin babies. Are they identical or non-identical? I happen to know these babies. I witnessed their vaginal birth in the hospital. In fact, they were VBAC babies. How cool is that? We all assumed that they were not identical. They looked incredibly different at birth. In this picture, they're 3 months old, and they still look different. As they grew during their first year, they began to look more alike. Their mom had a twin zygosity test done at 1 year. They are identical. It's fascinating that they looked so different when they were young. The reason is because they developed into significantly different space. The baby on the left had his head jammed into his mother's pelvis for weeks. The baby on the right didn't. My motto is, babies grow into available space. After these babies got themselves born, they had soft, available space in which to grow. This allowed their genetic heritage to come through. Next fetal factor is low amniotic fluid. Amniotic fluid serves many purposes. It acts as a cushion, a lubricant, and a temperature insulator for the baby. It also contains antibodies that prevent infection. The lubrication and buoyancy properties allow babies to float around and strengthen their muscles and bones during this time in the womb. Amniotic fluid also helps float and protect the umbilical cord, the baby's lifeline. Although the umbilical cord is pretty tough, they look so delicate and fragile due to their translucency, but if you've ever tried to cut one, even with very sharp scissors, you know how durable and slippery they really are. Reflexes and movement. As babies float around in the amniotic fluid, they experience touch on various parts of their bodies. They have reflexes that cause them to automatically move in response to these touches. The reflexive movements serve to strengthen their muscles so they can begin to voluntarily move and control their movements after they're born. Babies need strong muscles to participate in getting themselves born and then successfully seek the breast and self-attach to feed. So what is amniotic fluid anyway? At first, amniotic fluid consists of fluid from the pregnant person's body. Around 20 weeks gestation, all of that changes. Amniotic fluid is then produced by the baby. It's mostly urine. That's right, amniotic fluid is baby pee. Babies swallow and breathe amniotic fluid. This strengthens the muscles associated with respiration and digestion. They need this practice and strengthening opportunity to be able to breathe air and swallow milk once they are born. Around 30 weeks gestation, the ratio of baby to amniotic fluid tips in favor of more baby, less fluid. Prior to that, it was the other way around, more fluid, less baby. Because of this, the baby becomes less buoyant and more subject to the forces of gravity as gestation progresses. The baby's head is the heaviest part of their body. When the baby is less buoyant, they naturally move head down if they weren't there already. This is the normal scenario. Sometimes babies make an insufficient amount of amniotic fluid. This condition is called oligohydramnios. There are other conditions that may be associated with this, but for our purposes, we will concentrate on one of them, the actual mechanical effects of being a shrink-wrapped baby. It should be obvious to you by now that babies who have low amniotic fluid can't move around as well as babies who have ample fluid. They develop in one position and get born into the twisted shapes in which they developed if the low fluid condition lasted for some time. I also wonder about the primitive reflex development and strength building opportunities for these babies. Some muscles may be weak because the touch that would have stimulated their reflex-driven movements was insufficient or absent. Each baby's situation is unique. It all depends on how stuck they were, what position they were in, and how long they were stuck that way. Short umbilical cords. This illustration is admittedly freaky, but this baby does have a seriously short cord. Umbilical cords actually come in various lengths. Short cords are a little like a short leash. The baby can have less freedom of movement in the womb because of it. Cultural factors. This is the category we can actually do something about because the factors are under our conscious control, if we know enough and if we care enough. Most of the industrialized world still believes that engagement or fixation is normal. I believe it's pathology, far from optimal fetal positioning. This pathology is on the increase. The fact that people think it's normal contributes to the problem. If we think it's normal, we are disinclined to do anything about it. It is more common than it used to be, but common is not the same as normal. Caregivers who do not palpate. This is going to be a rant, so hang on. When pregnant people visit their doctors and many hospital-based midwives for prenatal visits, their providers don't necessarily palpate the position of the baby. They certainly don't do anything to enhance the positioning of the baby during these visits. They rely for the most part on ultrasound. They'll usually order an ultrasound at 36 weeks to assess the baby's position and also look at some other things. Rarely do they check at a prenatal visit for anything beyond whether the baby is breech or not. Any position that is not head down is considered breech, by the way. We know that babies need to have their chins tucked and their faces toward the parent's back. The center of the lambda, which is also called the posterior fontanelle or the posterior soft spot, should be pointing toward the parent's pelvic outlet for things to fit best. Do they check for this? Nope. Why is it like this? One reason is that obstetricians are also surgeons. It doesn't really matter to them if the baby is growing in an ideal position or not, because they can always do a cesarean surgery. Cesarean birth is safer than it used to be and is linked to better outcomes for doctors and hospitals in medical malpractice suits. Even though it is more dangerous than vaginal birth, the general public is pretty okay with it. In fact, one of the doctor's reasons to do this 36-week ultrasound is to determine whether and when to schedule a cesarean for a breech position. That's how they look at it. Another reason is that the level of palpation skills required to determine nuances of baby positions are rarely taught in medical schools or obstetric residency programs anymore. Some doctors cannot determine with their hands even the most basic element of a baby's position. Is the head up or down? Is it possible to figure out with our hands whether a baby's head is up or down, whether their chins are tucked, and whether they have their backs facing the front of the parent's body? Of course it is. I did it all the time as a midwife. If people are trained and get some practice, palpation is just as accurate as ultrasound for determining fetal position. It costs less, too. I'm frustrated by the number of people I see for the first time in my bodywork practice at 38 or 39 weeks. They say their 36-week ultrasound showed the baby to be breech and ask me what I can do for them. Of course, I do make enough space for some of these babies to turn on their own, but I also think to myself, where were you a few weeks ago when we could have done more about this? Surely these babies didn't decide to turn breech on the way to the ultrasound appointment. What do we do in the U.S.? We do external cephalic version at 36 to 42 weeks. These are rough-handed procedures. Doctors typically schedule only a half an hour to turn a baby. People tell me it's painful and stressful. Doctors typically schedule external cephalic versions no earlier than 36 weeks because there is a risk that the labor will have to be induced due to ruptured membranes caused by the roughness of the procedure. There's also a small risk that emergency cesarean will be needed due to cord compression or placental abruption. Of course, the rough-handedness and speed at which this procedure is done greatly contributes to these risks. By the way, guess which babies are hardest to turn? That's right, the ones whose presenting parts are engaged, fixated, in the maternal pelvis. The pregnant person in this picture is already in pain, and they've just barely gotten started with the procedure. Here's a picture of a midwife visiting a pregnant client. She's carefully palpating the position of the baby and may even give a little nudge one way or the other to encourage the baby to assume a nuanced, good position. It makes sense to me that providers should be palpating the position of the baby at each visit. That way, if the baby is in a less than ideal position, something could be done about it, such as gently maneuvering the baby into a better position and encouraging parents to alter their postural and movement activities early while the baby still has more buoyancy and room to move. But mostly that's not how it's done in the U.S. Baby lifting garments. It may seem counterintuitive because it looks to be, and is, wrapped snugly around the pregnant belly in this picture. However, notice that the thickest part of the fabric is actually below the belly. That's the tight part. The tight supportive part is high in the back and low in the front. This serves to prevent the baby from fixating deeply into the maternal pelvis. Instead, this baby gets to spend more time in the upper, more roomy part of the pelvis. When babies aren't stuck down low, they can move more. A baby lifter also prevents and provides fantastic relief from low back and pelvic pain during pregnancy. Many cultures have a version of this garment. In the U.S., if we use one at all, we tend to favor the industrial model shown here. It surprises me that when I recommend one of these garments, many people have never heard of them. I think all pregnant people should use one. I repeat, all pregnant people. The one complaint I hear about these is that they tend to be uncomfortable if the wearer is seated for a long time. There's a message in that. How does fetal constraint affect birth? Constrained babies have a diminished ability to free themselves from a less than ideal position and move into a more ideal position. I believe Mother Nature doesn't like to start labor when a baby is fixated or stuck. That's because babies rarely get stuck in ideal positions for birth. Ideal positions for birth are the ones that allow a baby to fit into and ultimately through the maternal pelvis with a little room to spare. If there's room to spare, babies will continue to move in a variety of ways, including all the way down and back up again until active labor dictates the ultimate one-way movement direction, down and out. I've observed that stuck babies' labors are often the ones that don't start on time. They may start and stop repeatedly over several days. Sometimes they seem like they're starting but never develop a consistent contraction pattern. Ultimately, even when babies are poorly positioned, though, labor will begin or more likely be induced. So what are some of the other things that make babies late? Typical human gestation is considered to be 37 to 42 weeks from the first day of the last menstrual period. It used to be that 40 weeks was the average. Now in the U.S. it's 39 weeks. This is due to a rise in inductions. Before I discuss why stuckness might delay labor, I want to mention some other reasons, the top 3, and acknowledge that in the end, Mother Nature knows best. Late babies do fall into some categories. The first one is genetics. This is one reason why a baby can be late. If you were late and or your mother and or sister carried babies longer than average, you're more likely to do it too. Length of gestation seems to run in families. Do some families produce babies that develop more slowly and benefit from more time in the womb? I'm willing to believe they do. Next category, firstborns. Statistically, first babies also like to stay in a little longer, about 6 days on average. It makes me wonder if first babies who have less experienced parents need the evolutionary advantage of more maturity to improve their chances of survival once they're born. This could help them survive while their parents get the hang of things, like feeding, for example. Feeding is hormonally influenced in the early days, but it's also learned behavior for both parent and baby. A more mature baby would have an advantage while waiting out the parental learning curve. I've seen many late-term preemies born at 37-ish weeks struggle at the breast and need lots of lactation support until they simply get a little older. Next category, boy bodies. Boy babies gestate longer than girls. More boy babies are born than girl babies, but by the end of the first year, more girl babies survive. Maybe there are good reasons why the boy babies want to stay in a little longer. One of them would be to gain more maturity. On average, newborn females born at 40 weeks are developmentally and physiologically 4 to 6 weeks ahead of their male counterparts, also born at 40 weeks. So there's no real evolutionary advantage with fetal constraint. The top 3 reasons for lateness, genetics, firstborns, and maleness, carry with them a potential for evolutionary advantage. When the reason is stuckness, labor delay can be a disadvantage. Post-maturity is a real thing. Over time, the placenta, the baby's temporary external organ, doesn't always function as efficiently as it should. We also know that, especially for older parents and parents with certain health conditions, longer gestation is statistically associated with some adverse outcomes, including a very slight increase in stillbirths. So we're back to fetal constraint and its relationship to the late labor onset. Why does it happen? I believe it may have something to do with the baby's presenting part not contacting the cervix at just the right angle. Now you may be saying to yourself, my baby was so low for so long, how could their head not be in contact with my cervix? I say angle matters. A chin not tucked or a baby head tilted toward one shoulder changes everything. I think this is especially true for an occiput posterior baby whose presenting part makes a stronger contact with the maternal sacrum. This is the genesis of the so-called back labor. And it makes a less strong contact with the cervix. Nuances of baby head position make a huge difference in the birth process. The onset of labor is part of that process. So once labor gets going, we then see the next set of consequences with stuck babies, labors that don't progress normally. Labor doesn't progress well if a baby is fixated. These labors take longer. They often stall around 6 to 7 centimeters of cervical dilation. If the cervix does completely dilate with a fixated baby, they still can't descend all the way to get born. Their presentations are more likely to be OP, asynclitic, military, or breech. All of these things are part of the recipe for a cascade of medical interventions that can lead to instrumental or surgical birth. Arguably, there's some wiggle room in this. I have seen babies born with their hand next to their face or with an untucked chin or their head tilted to one side. I myself gave birth to a baby who was born in the occiput posterior position. It's doable to get a baby born vaginally from a less than ideal or stuck position, but the odds are significantly higher that things won't go well. How are these babies' births medically managed? In most cases, we use intravenous Pitocin, which is synthetic oxytocin, to induce or augment labor that has stalled. When Pitocin is given during labor, the amount of endogenous, homegrown oxytocin, the love hormone production, dramatically decreases. Pitocin can't cross the blood-brain barrier. This is a big deal. This means that Pitocin delivers all the physiological effects, uterine contractions in this case, without the behavior effects, love. If that wasn't enough, IV Pitocin is released into the bloodstream in a more continuous way than the natural pulsatile release of endogenous oxytocin. You end up with higher blood levels and stronger, longer, more closely spaced uterine contractions. This can cause uterine hyperstimulation. When the uterus contracts, it temporarily decreases maternal blood flow to the placenta. This temporarily decreases the flow of oxygen to the baby. Normal pauses between contractions compensate for this. Long, strong, closely spaced contractions can compromise a baby and lead to a cesarean birth for fetal distress. An induced or augmented labor requires closer monitoring because of this. Back in the 70s, when I gave birth, I estimated that in 10 years or so, almost everybody would choose unmedicated birth. The benefits of opting out of narcotics for pain relief in labor seemed like a no-brainer to me. I figured that once people understood how narcotics adversely affect our babies, anyone in their right mind would choose natural birth, right? Obviously, I did not see epidural anesthesia, the Cadillac of childbirth drugs, coming down the pike. Nobody in the natural childbirth movement did. Epidurals are considered regional anesthetics. They bathe spinal nerves and render the birthing person numb and less mobile from the waist down. They provide great pain relief in childbirth. Epidurals can slow contractions, leading to Pitocin administration to speed things up, or more Pitocin if it's already part of the project. Epidurals decrease oxytocin release and its peak at birth because the vaginal stretch receptors are numb. We know that epidurals are associated with an increase in OP, asynclitic, and military presentations. They are also associated with an increase in instrumental births, like vacuum extractors and forceps, and also surgical births. Cesarean births are safer than they used to be. They have high cultural acceptance, and they are more dangerous for babies and their birthing parents than vaginal births. People who have cesarean births are 80% more likely to have complications than those who give birth vaginally. The risks are lower for babies, although I can't stop thinking about one of them. 1 or 2 babies per 100 are cut during the surgery. Which factors are most responsible for fetal constraint? Is it maternal factors, cultural factors, or fetal factors? So in case you weren't keeping count, it's mostly cultural factors and a few maternal factors and very few fetal factors. And the good news is that we can do something about all of the cultural factors and most of the maternal factors. So what are the sequelae of fetal constraint? So we've already talked a lot about the twisted babies and the babies with feeding difficulties. So let's talk about primitive reflexes. In my world, lots of people are talking about primitive reflex integration. Reflex integration is the process that causes reflexes we have developed in utero to gradually extinguish. This is supposed to happen as they are replaced by coordinated voluntary movements. When it doesn't go well, we see sensory and developmental problems for older babies, children, and adults. So let's look at the rooting reflex. When a baby's cheek is touched, they turn their head toward the touch and open their mouths. If that touch came from a nipple, they are on track to get fed. If an adult turns their head and opens their mouth every time their cheek gets touched, it's a problem. The reflex is supposed to be temporary. Lately, I've become more interested in the question of what happens when the primitive reflexes never develop optimally in the first place. So let's go back to the rooting reflex. If this reflex is absent or weak, it makes feeding harder for a baby. The parent has to assume part of what normally would be the baby's role in order to get the baby fed. What happens when the reflexes are established but don't have the opportunity to stimulate muscle development and strengthening due to fetal constraint? In the case of the rooting reflex, it may be present, but for a baby who couldn't, for example, turn their head to the left in utero, the muscles that should turn the head to the left are weak after birth. This baby would have a harder time feeding at the parent's right breast. The reflexes themselves are responsible for strengthening babies' muscles in utero. More importantly, it endows babies with the skills they need to get born and survive life on the outside while they are learning to voluntarily move their bodies. This strength building thing in utero is super important, especially in terms of our understanding about what's really happening with the babies who've experienced fetal constraint. Nowadays, we are really changing up what we offer to these babies in terms of treatment. We're given a ton more homework than we ever used to give. And one of the reasons for that is muscle weakness. It's interesting to me that it's still common for me to see infants, parents bring them in for treatment, and they already have a diagnosed torticollis situation going on, either a rotation or a lateral flexion pattern, doesn't matter which one, or maybe both. And they've been given stretching exercises by a well-meaning physical therapist or perhaps a chiropractor, some other practitioner. And I'm here to tell you that stretching does nothing to resolve these conditions. These babies aren't tight on one side. What's happened to them is that they are weak on one side, and what they need to do is a consistent program of home strength building. For example, let's say a baby has a head turning preference to the baby's right side. So what we have the parents do and what we teach them is how to make being on the belly an enjoyable activity for a baby, and there are lots of tricks to make this happen, and get this baby on their belly as much as possible, and with face-to-face social engagement, encourage the baby to lift their head against the force of gravity and turn it in the non-preferred direction. This is how they build strength, and like any strength building exercise, they got to go to the gym every single day, and they have to do it several times a day. There are other things we do for lateral flexion patterns, but none of them are stretching. They all involve strength building because that's what these babies really need. It's really unfortunate that our cultural practices, the way we care for babies, is really exacerbating some of the problems that we're seeing, really all of the problems that we're seeing as a result of fetal constraint, because we also engage in infant constraint. We've got babies who are sleeping on their backs, who are swaddled for sleep many months into their little lives outside the uterus. We have babies playing on their backs. We have babies in infant furniture, strollers all the time, car seats all the time. For some reason, we love immobilizing our babies. Really, the only reason we have brains is to move our bodies. All necessary elements for life require movement. There are no exceptions to this rule. So what about cranial nerve dysfunction? Cranial nerves emerge from the brain stem. They are responsible for sensation, function, and movement of certain body parts, especially in the head and neck. They affect posture, tongue function, vision, eye movements, sense of smell, hearing, digestion, and sense of taste. The muscles that drive suck, swallow, breathe coordination depend on appropriate cranial nerve function. Cranial nerves also stimulate facial expression and vocalization, the primary tools of social engagement. Cranial nerve dysfunction is associated with asymmetries. Sometimes this happens when a baby is stuck in utero, especially for a long time in an asymmetrical position. It can also happen if the baby has a rough birth, which, of course, can be caused by fetal constraint. When fetal constraint affects the cranial base, it can compress cranial nerves. This may inhibit normal sensations, movement, and function. Compromised cranial nerves will ultimately cause more asymmetries in the body. So here's an example. A baby has cranial base compression that affects spinal accessory nerve on one side. This causes weakness in certain neck muscles on that side. Consequently, the baby is born with a head-turning preference. Cranial nerve dysfunction also causes autonomic nervous system dysregulation. These frequently upset babies seem to be raw. Their response to typical stimulation is way beyond what we would expect. Babies, even the dysregulated ones, learn emotional regulation from their parents and caregivers. We regulate them with nurturing, soothing behavior. I'm going to get on my soapbox for a moment. I hear many people say they want their babies to learn to self-soothe. They may ignore their baby's cries in an attempt to facilitate this self-soothing. At some point, babies will stop crying if no one comes to their aid because they will have fallen into a state of despair. Babies don't actually have the limbic system, which is the feeling brain, support to begin to learn self-regulation and to soothe themselves until they're about 3 years old. The entire process takes many years throughout childhood and young adulthood as the neocortex, the thinking brain, develops. The developmental timetable can't be rushed or trained. So what about the not-so-subtle things? Club foot. This baby's foot and ankle grew this way because they didn't have the physical space to grow normally. Babies grow into available space. This baby's club foot is being treated with a series of casts that restrict foot and ankle movement and growth in the undesired direction. The casts allow movement and growth in the desired direction. They're changed frequently to accommodate the baby's growth and the shape changes that slowly occur from the casting process. This is another great example of babies growing into available space. If they gestate asymmetrically, it's possible to change things after birth if corrective measures are applied early and consistently. Growth fuels the change. The rate of human growth generally slows from conception forward, with a slight uptick in puberty, obviously. Babies grow fast, but every day this growth rate slows. Sometimes surgery is required to resolve clubfoot. Torticollis. Years ago, I typed torticollis into the search engine for iStock photo, and this is what I got. It's also the most frequently undiagnosed problem I encounter in my bodywork practice. It's a key player in positional plagiocephaly, flat spot on one side of the baby's head. You can't have positional plagiocephaly without underlying torticollis. So we used to call it wry neck syndrome. Some babies appear to favor rotating their heads more to one side than the other, or they may have a lateral flexion preference, which is a head tilt to one side. It's common to see babies who have both. Torticollis looks like a neck thing, but it's actually happening throughout the torso. It has potential to extend into the floor of the mouth and adversely affect tongue mobility and feeding, and we've already talked about that. Even if the restrictions don't extend into the floor of the mouth, these twisted babies may simply have a difficult time breastfeeding on one side or in certain positions. The twist can also extend into the cranial base, contributing to cranial nerve dysfunction due to compression. Of course, the entire spine and pelvis are also involved. Could this affect a female baby's future experience of pregnancy and her own baby's gestation, birth, and development? I say yes, the potential is there. Hip dysplasia. Lack of fetal mobility causes hip dysplasia. The hip joint is a ball and socket joint. The socket part of the hip joint is called the acetabulum. During gestation, it starts out shallow. The ball at the top of the baby's thigh bone or femoral head is supposed to press into the acetabulum, causing it to form a cup around the ball. If this doesn't happen, the joint remains too shallow and it's unstable. Hip dysplasia is more common among babies who are stuck in a frank breech position. Frank breech is where the baby is jackknifed with their pelvis jammed into the maternal pelvis and their feet near their faces. This position pulls the femoral head away from the acetabulum. Any baby can get stuck in a position that creates the conditions for hip dysplasia. Frank breech isn't the only way. Scoliosis. Lack of fetal mobility causes scoliosis. Scoliosis is usually diagnosed in school-age children. I assert that it's been there all along, since before birth. We don't usually see it in babies because they haven't yet spent time standing and walking in gravity. It's the upright position in gravity and that drive to keep the eyes facing forward and level with the horizon that cause the compensations for scoliosis to appear. These compensations are what we actually see. The muscular length and strength imbalances on either side of the spine and the apparent lateral curvature of the spine, which incidentally is actually a rotation. I believe that scoliosis is a torsion in the deep structures anterior to the spine, structures like the mediastinum, the root of the mesentery, and things we call ligaments that are actually folds of peritoneum, which is the lining of the abdominal and thoracic cavities. They attach thoracic and abdominal organs to adjacent structures. These torsions develop in utero. Some people say scoliosis runs in families. I say a big baby who gestates in a woman with a short torso is what runs in families. More on that to follow. I'm going to end this presentation with a personal story about fetal constraint. So this is my husband, Steve, and our dog, Roy. Steve was diagnosed with scoliosis as a small child. He had what's commonly called the C-curve variety. When I looked at his back while he was standing or moving, it was obvious. He said that in his yoga practice he could twist in one direction, the direction of his rotation, with ease. When he tried to twist in the opposite direction of his rotation, he felt like he was spring-loaded. He could barely twist that way. So 9 years ago, Steve had a liver transplant. Now his scoliosis is completely gone. It's obvious to me that it's completely gone when I look at him while he's standing and moving. He also reports equal twisting ability in his yoga practice. So naturally, this got my attention. So I asked one of the surgeons on the transplant team about it. I wondered if they had cut out his old liver and then somehow the support ligaments repositioned themselves before they sewed the new liver into place. Well, the doctor told me that they only attach the blood vessels and the ducts. The rest of it scars into place. So Steve had resumed his yoga practice post-transplant before the doctor said he should. That probably helped him gain maximum mobility for his new liver and the adjacent structures. I'm really glad, though, that he didn't resume running sooner than they had advised. So Steve was a nearly 10-pound baby who was 21 and a half inches long. He developed as the first-time baby in the womb of a woman with a short torso who was 5 feet 1 inches tall. I contend his scoliosis was due to lack of mobility in utero. Thank you for watching my presentation. I hope you enjoyed it.